All this is Dr. Mobeen Sayed. Welcome to one more show. So, what do you think about this background? It is still work in progress. It is white in color. I wanted black. But, anyways, plus the camera angle is different. So, hopefully, this is a little better. Um, my apologies. I took some time because I was trying to find out the questions on Twitter. I could not find my own tweet under which the questions were. My apologies. So I'm going to go back to YouTube and start answering the questions there, and then I'll toss between the live questions and the previously given questions. So let's start. So Gift says, love the new bookcase. Tell me this, how is the audio? Kelly says, nice angle. Yeah, so previously the camera used to look down on me, possibly look down upon me as well. The reason for that was that around this mic, I had a shield, and then the camera would look from above that downwards. I removed that shield, and that was a cool bean who had actually suggested it. But I'm going to put the sound absorbent foam in the room itself. So hopefully that would help. So Paul Borg says audio is fine for me. Thank you very much. I also removed the audio. There was a filter here. I removed that as well because I thought it was making the voice a little more muffled. Margaret says that audio is improved. Thank you, Margaret. Dream Reader says it looks great, sounds fine. Thank you very much. Sandy says fine. DDS says fine. Thank you. Dr. Z is here. Dr. Z, after a long time over here. Thank you. I was actually thinking about you that, hey, I've not seen Dr. Z for some time. So thank you for being here. Doug says us. Denise is here. Kelly says nice. Love the new bookcases. Thank you very much. Books are still the same, although this cupboard was filled with my children's novels, or the books for them, and I brought them downstairs and I brought my books up here. Doug says audio is good. Excellent. So Dr. Z says everyone has been very busy. Welcome. Nipa is here. Nipa, how was your Diwali? So love the plants. Thank you very much. I have one over here and one over here. There is one more which is somewhere. So these used to be under a constant light to help them. Now I don't know if they are sitting here, if they would start, shriveling because of the light's absence. We'll see. What do you think about this? So these, I have a big box full of various awards and shields and stuff that I've gotten in my life. So I just brought some of them over here and put them here. Janet says the sound absorbent will never absorb Luffy's commentary, but you're doing well. Thank you very much. Okay, so let me make it valuable for you. Let's start. So I'm going to share my screen. Gift says the glowing yellow. Where did it go? Here. The glowing yellow is nice and sedating. Thank you very much. Coleman says pathos do well in low light. Yes. Okay, so love the words. Nice touch. Thank you very much. There's so many downstairs, and then there are bags of animus. I am still who I am. All right, so let's start. Our discussion started last time with Luffy. Then we talked about the trial 5 to 11. When the adaptive immune system learns its just collection, we answered that one. Asymptomatic infection and infectiousness, please explain. I did that. Dear said, why breakthrough infections can't act as booster in a normal subject? Regards, Dr. O.N. Sinha. So, Onkar Nath Sinha, very good question. And the question is, why is a breakthrough infection not a booster? It is. What is the booster? So let's just very quickly see the role of a booster. Again, for the booster or the vaccines, there are two reasons for them. One is to receive them for protection, and the other one is to receive them because there is a passport or a mandate and then the immunity acquired because of the infection is ignored. And it is not the case in all countries. There are many countries that recognize the infection and the immunity as a result of that, and then there are countries that do not. So now, if we look at the booster, so let's say here was dose one, this was dose two, then we know I need to move this a little closer to draw. The setup is still being worked on. So with this, we know that after a week or 2 weeks, then the actually antibodies would start getting built from here, then they'll get a boost here, and then they'll go. So this is dose one and two. Then these would start declining, normal, natural process, no fault of the vaccine, and it also does not mean that the person is not protected anymore. Then when you give a booster, booster would ramp it up again, and it would activate the immune system once more, and it would cause more memory cell and more affinity maturation and more cytokines and more activity against this particular antigen. However, an infection here will do the same thing. And I have to always, even after saying this for months or years now, unfortunately, pandemic has gone into years, that an infection is not something to go after. An infection is not desirable. So whenever I say an infection, I don't mean to say go get infected. I never have said that or suggested it that way. I don't want you to be infected. It is dangerous. However, if a person does become infected here, then that is equal to an exposure to the antigen. Same thing as a booster. Booster is a safer, let's make air quote and say relatively safer. But I would say safer than the infection itself. Infection can be dangerous. So booster or the infection is an antigen. I would argue that infection actually brings in a more varied kind of antigen set, because infection is not going to just bring in the foot of the virus or the spike protein. Infection is going to bring in the whole virus. And the whole virus would mean more antigens, not just a spike protein. And that would mean even more training for the immune system for even more kind of parts of the virus. While a booster would just bring in the spike protein or whatever the booster is made up of. So, to answer your question, then, uh, why breakthrough infections can't act as boosters in a normal subject? So, again, it has to be normal, healthy human being, and in this kind of a state, no compromise of the immune system, no variation, which is very different, etc. And then, yes, they are a they are another exposure. Any new news on the pathology of neurological endothelial vaccine side effects and long COVID? So John Titor says, any new news on the pathology of neurological endothelial vaccine side effects? So John, you may have seen that we had with us Sean, who talked about the neurological symptoms. I really want to dedicate more time on two things. Number one, offering more data around vaccine efficacy. Just like we talk about vaccine issues, we talk about efficacy as well. And I want to make sure that we can talk about the efficacy and where is it actually protecting. And then the second part, I really, really want to dedicate my time more towards the neurological issues. The problem is there are just so much that is happening. But hopefully, as I've come to this newer room where I can close my door and I can go live anytime I want, hopefully I'll do more talks and more often. When you talked about, so A says, when you talked about Ngenic, it sounded like it could solve almost anything in a perfect world. Would it be possible to use a similar technology for muscle wasting disease, etc.? I think I'll qualify my answer by saying this, that what their technology does, and by the way, there is a good news, and Genix CEO and maybe their technology team members, technology meaning vaccine technology team members, they would join us in a live talk, maybe I think in about a week or 2 weeks. So that is exciting. Now, answering your question about the muscle wasting and the so Nginx technology is this. So let's say we have a cell here, and we have another cell here, and we have another cell over here. There are three cells. They're all standing here. They are talking with each other. They're having fun, and they are cool cells, right? So here, here, here. And now imagine one of them is a T cell and a B cell or a muscle cell. So let's say this is a muscle cell. Although if it was a muscle cell, it won't be rounded like this. It'll be kind of like long and cylindrical. But imagine this is a muscle cell. And then there is a B cell here, and then there is a cancer cell here, meaning different kind of cells. When there are different kind of cells, those cells, the technology that Ngenic, now this is bothering me that this is a muscle cell and it looks circular. Okay, so the Ngenic technology does this. What they do is they have their, it's beautiful technology, I love it. Here is their particle, some it microscopic capsule, right? Nano pill. They attach that, it's such a beautiful technology. They attach that with an antibody that can bind. Remember, there are antibodies that can bind to any patron. This is like a magnet. So they make an antibody that binds to this patron. So imagine this is equal to, so if we have a cart, a horse pulled cart, and then the cart has these little things in front with which you can bind it to a horse or tie it to a horse, bind it to a horse. I have weird English expressions. Okay, so here we have a cart, right? Imagine these red things are antibodies, and the cart has a bunch of medicine loaded on it, right? So this is the medicine. Now, here there is a cell which we want this cart to go to. So we have cell 1 and 2 and 3. We can teach the cart on the other side to be able to bind to one of them. And why one of them? Why not all of them? Because all the cells in our body have some unique marker on them. Just like we human beings have different face. And you can, even when it is the same set of features, we have eyes and nose and mouth, we still have different face. Similarly, all these cells have different markers on them. These are called cluster of designations. Cluster of designation. These are cluster of proteins that help us designate one cell type from another. For example, the B cells have a different set of proteins on them, and we can identify them and say, okay, this is a B cell. And the T cells have a different set of proteins on them, and we can identify them. Similarly, a muscle cell would have a different set of proteins on them or markers on them. Just like people in uniform wear various kind of tags and badges and stars and stripes. Now, if you attach the other side and make it able to bind to a specific cell's marker, then this whole thing, this whole capsule can be delivered to that cell only. And now if you fill this thing with some medicine, then that medicine will not go everywhere. It would only go to that cell. So now to answer your question, A, muscle wasting, there is an autoimmune type of muscle wasting in which there is a destruction of the muscle cells, or there is a destruction of the muscle neuromuscular junctions, or destruction of the nerves, or there are some diseases in which there is lipid, I believe, filling of the cell. So depends what kind of a wasting it is, and then what kind of a drug that is needed. If there is a drug that can be specifically sent to the muscle, then this technology can be used. Okay, so I'm going to answer some of the online questions and then go back to that one. So let's see here. Blank Blank says, long time no see. Dr. Mubin, have you heard anything about Manitol for wax injuries related to neurological symptoms? Thank you. No, I have not. It is an interesting thing because mannitol's function is to reduce the um, it is an osmotic diuretic, meaning it pulls the water out, which can then reduce congestion. And reduce congestion, for example, if it is in neurological cases, there is congestion in the brain, mannitol would help reduce that and possibly reduce the symptoms. So, very interesting point. Um, Anthony D. Stefano says, antibodies naturally wane after any infection. Yes. Why do we need boosters? Because, so I'll give you two answers to this. Also, antibodies raise hematocrit levels, increasing blood viscosity and cardiovascular issues. Are IgGs healthy in high constant concentration? Good questions. And I know where you're going with this, and let me answer this. I'll answer this question in multiple ways. First of all, legitimate need for a booster and antibodies. For example, somebody who is immunocompromised. Now, who are the people who could be? I cannot name them all. I cannot list all the pathologies, but there could be people who have cancers. There could be people who are actively given medicines like steroids to suppress their immune system to protect them from some autoimmune diseases. There could be people who have organ transplant, and we are trying to keep the immune system in check so it does not attack that organ. There can be people who are infected with the viruses or pathogens that can cause immune systems issues, and so on. So there are many, many reasons. In such folks, it is possible that even the infection or the vaccine is not able to generate enough level of the immune response that is protective. And we are seeing that many of the vaccine breakthrough infections or more severe outcomes are in those who may have such comorbidities. So in such folks, giving a booster is actually fine because they already have lesser number of antibodies produced, and booster would only help bring it towards what it should be. So booster is important here. Secondly, booster can be very interesting for someone whose normal system is normal, whose responses are normal, but their immune system has become ramped down. It has become ramped down. And let's say they are going to be exposed, for example, healthcare workers. And we don't want them to get infected. Instead, we would rather keep their immune system higher up. And so then a booster may be needed. Now, interestingly, it seems to me so far that this placement of boosters for healthcare worker is being pitched as this would be the third dose only and that's it. But I think we'll have to wait for 6 months to see. And this is really, if I was the decision maker, if I was going to say that, hey, we need to give this. And when I say I was the one, I'm not asking for a job or looking for a job. I like my independence in this talk, although people still want to silence me on daily basis. But when I say what I mean is that decision making could be done differently. And that could be, instead of just saying, everybody go get a booster, one could say, hey guys, let's say healthcare workers, you address them and you say, if you would like a booster, you can take one. And here are the possibilities of where the booster may be needed. If you're a healthcare worker and you yourself have comorbidities and your antibody levels may not be high enough and you may get exposed, maybe a booster is great for you. Or if you're a healthcare worker who is concerned that you had the vaccine a year ago and maybe your body is not in the right state or the variant has changed, maybe a booster is good for you. So if a plan could be given, instead of saying everybody go get a booster, I think it would have had better outcome. And not only better outcome, it would have, again, healthcare workers are getting it. They are, majority is getting it because they have to. But it could have been a more structured, more planful, more thought out, more wise approach. I don't think it would have taken um, more resources to offer such structured thinking. Anyway, so that is the first part. Antibodies naturally wane after any infection. Yes. Why do we need boosters? So some examples of booster need here. And then, as you can tell, there is a third example as well, and that is policy. That hey, the booster, maybe body is not in a need of a booster, but the policy is made. Also, antibodies raise hematocrit levels. So that, let me just very quickly explain it. And I want to make sure that we are on the same page here. So imagine we have some blood here in this bag, right? So this is a bag and this bag has some blood in it. Hematocrit is really the, or let's make it just very simple. This, the blood has multiple parts in it, correct? So blood has fluids in it, it has electrolytes in it, and it has cells in it. And we want the fluid part of the blood to be a particular percentage. Let's say we want 60% of the blood to be fluid, and the remaining 40% can be cells and proteins and other things. That's our hematocrit. And we want the blood to stay fluid so it can run around in our blood vessels and slip and slide and flow correctly. Now, if you add too much proteins to it, or too much cells to it, or reduce the fluids from it, then what happens is that the amount of fluid, so now I'm just going to make this so I don't waste your time drawing it again and again, although I love drawing. So imagine this is the fluid. So now let's say the fluid and the solids in the blood are 50-50, or the fluid has become now 40% and solids have become 60%. This could become actually incompatible with the life of a person, because the fluids cannot move. Some of the cancers are that way. So now if I go to Anthony's question, Anthony is saying, hey, if we add more proteins, antibodies are proteins, aren't we going to change the consistency of the blood and make it more kind of milkshakey, more thick, or increase the viscosity of that? And so it would become difficult for it to move. Totally agreed. However, Anthony, if you talk in the context of vaccines or even infections, there is not going to be so much of antibodies that the viscosity increases so much that it becomes dangerous for body's function. Usually the hematocrits start changing when we have carcinomatous situation where there are too many cells being produced and continuously being produced, or there is too much proteins coming from cancer cell which is just bombarding the body from making proteins. So vaccines can't do that kind of a thing. They cannot produce so much of the proteins to just cause viscosity issue. But if we say for an exercise purpose, let's say if a vaccine produces enough proteins to cause the viscosity, then your question is correct, that that viscosity would become an issue for the cardiovascular system. And finally, are IgGs healthy in high constant concentration? So generally, people have chronic diseases, they have chronic infections, and their body makes IgGs, and they're fine. So this kind of IgG level is not dangerous. But as I said, there are levels where if that is because of IgG or that is because of cells or other proteins, it can become a problem. But a booster would not do that, or after a vaccine, an infection will not do that. Good question. Loved it. Okay, so let's see if there is more question. Colin Hamill is here. Colin Hamill, hey Colin, how are you? Does tetanus not mutate since tetanus boosters are years between them? Why are COVID-19 shots so close? So I think there is a part which is mechanism, and then there is a part which is observation. Tetanus does not mutate as we see the SARS-CoV-2 need, or more than flu, for example. I think that SARS-CoV-2 is a coronavirus. It doesn't mutate as much as flu because the coronavirus has the proofreader enzyme in it, which keeps it more stable. And one good example of that is that Delta arrived here, what, last year? And we are still with Delta. There are millions of variants, but they're not taking hold. So why are COVID shots are so close? This is an interesting one, and I think the, only vaccine companies can tell why they decided that way. I can just give you a conjecture, and that is the dose one was actually not known for what should be the quantity. So imagine if we are making a vaccine together, and so we say, all right, this is a vaccine we're going to make for the first time. And then our discussion becomes, here we are sitting, the cool beans, we created a company, we're making a vaccine, and saying, all right, what should be the vaccine's concentration? And the problem is to solve is how much concentration should be enough to provoke the immune system enough to create cells and antibodies. But this is also not that much that it causes severe side effects, right? And this is also good enough to create some sort of a long term response, meaning immunity for 2 years, 3 years, enough of the immune system being, um, triggered. And we don't know what is really the right concentration because we have never seen this kind of a vaccine. We've never made this kind of a vaccine. So we are scratching our head. So what you do is you say, you know what? Let's do this. Let's try to make the minimum amount of concentration which we think would be important from our previous vaccine manufacturing or from other literature. And let's say this is 10 microgram. And we would administer that, and maybe we will see the people and see the responses, and maybe a month later we'll give another 10 and see if that works out. And this way, maybe we would reduce these side effects while we would ramp up the immune system. Plus, there is not enough of a distance between them to create too much of a risk of not efficacy. And there is just enough distance in there as well that a higher dose in one dose may not be, may be prevented. So these are the kind of thoughts. So I think this two dose, one dose, this was really a non-scientific schedule, but based on mechanisms and hopefully the desire to reduce the side effects. And I think now they're finding out, for example, in the case of Pfizer, that they're saying, hey, we actually think there should be a third dose. Now, it seems to me that they are saying third dose and after we're done. But who knows? Because we still do not have the right science available to us for this vaccine. Kelly says, I would like to volunteer for testing a baby dose. Yeah. So the part of the first phase 1 and 2 are actually to try to figure out what dose is correct and would not cause too much side effects. So every trial has that dose calculation or dose understanding as well. This is a good question. Doug has a good question. So the good question is, and I don't really feel that I have a good answer, but I'll try. So the question is the concept of energy. And I was hoping, so this is how many months now we've been talking, um, somewhere in March, April of last year. So April to April, 1 year, and then another. So 1.5 year. I was hoping someday somebody would say, "Hey, what is energy? Talk about that." So, Doug, thank you for bringing it up. Energy is this. Imagine that we have a cell, our cell. Let's say this is a liver cell. I'm just making up some cell, liver cell. We have done this discussion in the past that when a cell makes something in it, what does that mean? That means it makes its proteins, right? Our cells are always making things in it. When it makes something in it, cells do this funny thing that they always present whatever they make outside on their surface as a sampling. Imagine every time you cook food, you always put some part of it outside to say, hey guys, my neighborhood people, come and sample this. So these are self antigens. These are parts of the cell's functioning machinery, and the cell is presenting it. And there is a problem. The problem is if with this antigen, we would always have naive T cells that would come and attach here. And they will be always like, oh wow, what is this? So that would happen. Mouth should be like this. That would happen. However, the concept of energy is that our cell would ignore this. The immune system cell would ignore this. And for ignoring it, that process is called energy. To ignore it, one is the training of the cell. The cell is trained in the thymus, for example, a T cell, to say, hey, don't attack our own cell. So the cell is already in an energetic state for self tissues. Then there is further energy, and that is where Doug is pointing to, and that is repeated exposure to something will also cause a cell to become energetic to it. Cell would say, you know what, I'm not going to bother killing this thing, it's everywhere, and it must be self. So that is also called energy. Now, if we read Doug's question, can repeated vaccine dosing cause energy or other tolerance? Answer is yes. If you repeat and repeatedly expose the body to a, an antigen, ideally the body should continue to respond to it if it is a foreign antigen and was not originally looked at as a self. So the energy capability towards non-self is less because we already only select those cells to survive in us that do not respond to ourselves. So they're already kind of inclined toward energy for us, but they're not inclined towards energy towards other things. Secondly, energy usually occurs when the exposure is continuous within our body. So, for example, let's say we have a um, organ transplant, and that exposure is continuous. Even then, we have to tell our cells not to attack it. So, the very first part of good condition of energy is that the cell is trained to ignore ourselves. If it is not trained to ignore other cells, usually it does not develop energy that well, but it could develop some tolerance. Vaccine boosters given every 6 months or so would not create, in my opinion, from a mechanism point of view, it would not create enough exposure for the immune system to say, you know what, oh well, I'm not going to respond to it. And I'll give you another example. For example, strep throat occurs very often in us. So streptococcal or staphylococcal infections happen very commonly, but we respond to them because we don't become allergic to them. Good question. I love this question. Okay, so 1 second, I'm gonna answer something here. So Robin says, would love to see a discussion on the various ivermectin protocols people are using, maybe comparing them for prophylaxis and also early treatment. Okay, so let's take that up as a separate topic. Good question. Tasha says, is the vaccine safe for someone who had reactivated EBV from COVID? Do you still recommend FLCCC for long haulers? So, FLCCC for long haulers, I was part of this and was leading it. So, of course, I recommend it. I feel that there is one thing that I wanted to actually reach out to FLCCC to say maybe we should add that, and that is the naltrexone. Low dose naltrexone, I have heard so many folks responding very, very well. I haven't directly prescribed it yet to my patients. I'm still sticking to the older habits, but naltrexone I'm seeing is doing wonders for long COVID, especially with the neurological symptoms. So that is one change. If I want, I could, and I should reach out and ask them. Other change, I still believe that Moraviroc at some point needs to be looked at again to say, can we add that to iRecover? Otherwise, still for long COVID, I'm seeing globally majority of the prescription set uses iRecover. So that is one. Now, the is the vaccine safe for someone who had reactivated EBV from COVID? So that's an interesting question. I have a friend who has a EBV reactivation, and the doctors are not giving them vaccine to say wait till EBV reactivation is gone, and they are actually waiting for 3-4 months now. So now going to your question, this is more of an anecdote for how some doctors are approaching their patient. um, EBV reactivated and COVID is known in some studies, and I have shared those studies to activate or reactivate EBV. What I do not know is if EBV is already reactivated, then will COVID further aggravate that or not? I do not have data or I haven't seen a study for that. So, this part of the question, Tasha, is something I can't answer. Garrett says, when is Dr. Keith coming on your show? That reminds me, I have to have Dr. Keith on our show. So, let me actually send a message to my assistant right now. Okay, message sent. Good reminder. Okay, so now to the live side here. And my apologies, I have to do this balancing of offline questions and online questions. So let's see. I saw a super chat. I saw another super chat before this, which unfortunately has gone on. So Melvin Watron says, our faith, Islam, forbids us to believe in contaminations because who infected the first? What do you think about this? Melvin, I I don't even understand the question correctly, so my apologies. Um, forbids us to believe in contaminations because who infected them first? Can you please? I would look at your question further. Can you elaborate a little more? My apologies for being a little thick. Um, there was another super chat I saw. I want to make sure that people don't think they super chat it and then I don't respond. Here, Guy G's says, Why does it matter if spike protein enters the nucleus and wreaks havoc when all cells that express the spike protein are swallowed up by the immune system or kill themselves if they can't repair DNA? Good question. And short answer is no, it doesn't matter. A little longer answer. And I was going to do a separate discussion, so I would do that as well. The concept in that study, I think I tried to make this clear as well, but I'll say it again and I'll do a separate discussion. They had transfected these cells, right? So these cells were transfected, meaning in them they had added genes. Is it the correct spelling for gene? Genes to make them look like B cells. For example, they had added the genes for diversity, variable VDJ parts, and the constant part, antibody making parts. That was an infected, transfected cell. This does not, SARS-CoV-2 normally does not infect a B cell. So what they did in vitro was kind of not a true picture of what will happen in us until somebody researches it and comes back and says, yes, I see this in vivo as well. So that's one. Second part, that the spike protein that they produced here, spike protein that they produced over here, which got located um, to the nucleus, you are correct that the cell that would express the spike protein usually will get killed by the immune system. So this is destined to die. However, it is possible that some cells, so now it is a conjecture. Please don't take it as a mechanism that is happening. This is not a possibility yet. We have not seen it. So allow me to have a scientific discussion and a scientific conjecture here without saying that Mubin said this would happen. So here is the conjecture. Conjecture is this. Let's say we have a B cell, or we have another cell, just some cell, general cell. And that cell has a spike protein in it, multiple spike proteins in it, because of the infection or because of the vaccine. One thing I thought was incorrect on the author's point of from their point of view, that their conclusion was, well, the vaccine should not be the spike protein. This is, infection can be the same way dangerous because virus is going to produce spike proteins as well. So because when they say vaccine should not be full spike protein, it kind of made it look like, oh well, the vaccines are wrong. Infection would do the same thing, and I mentioned it in my talk. So here we have antibodies being produced, spike proteins. Some of them got co-located. How that still is interesting. So they got co-located. They impaired some of the break repairs, which made the cell a cancerous cell. Now, if it became a cancerous cell, then this cell can start evading the immune system. That is what cancerous cells are. They just don't respond to the immune system. So, F you, I'm not gonna. Normally, what happens is a cell that we don't want, we give it a signal to say, kill yourself, commit apoptosis. It still is cell's function to activate the machinery to kill itself. So somebody would just whisper to it and say, hey, you should kill yourself, this is, you're not doing well. But cancerous cells stop responding to apoptotic signals, and they also turn off their internal apoptotic machinery. So there are many mechanisms for cancers. So it is possible, now this is a conjecture, I'm just extending their theory, it is not a mechanism observed. It is possible that when the spike protein enters a cell's nucleus, causes the damage repair impairment that might cause a higher tendency to develop a cancer. Once it is cancerous, it's not going to respond to whatever immune cells want. Cancer cells exhibit a lot of antigens as well that ideally immune system should pick up and kill them, but they evade it. So that is the possible risk. But let me repeat it so that I'm not causing any confusion. In that study, they manufactured B cells and then they put the genes for the spike in them. In vivo, SARS-CoV-2 does not do it to the immune system cells. So hopefully that guy, geez, that's a good question. And some of them will be killed. For example, let's say the spike gets into the cell and causes enough impairment of the damage repair that the cell just dies. If a cell, our cells are sharp. If they know that I can't survive, they're going to die. Or if outside cell can figure out that these cells are really not good, they're going to kill them. But if somehow the DNA manipulation occurs in a way that the cell becomes cancerous, we even can handle cancerous cells as well and kill them all the time. We are developing cancerous cells and we're killing them. But if one cell escapes, that is a cancer. Now, is that possible? Have we seen it? No. Is that in vitro study actually a representation of what happens in the in vivo? No, until somebody comes back and says, yes, I saw that. Nobody has seen it. This is a manufactured in vitro study. So Sasha says, thank you. Colin has one more question. Are all cancer cells immortal cancer cells? That is the definition of a cancer cell, that it is immortal, at least immortal in a way that it can keep making more cells and it can keep evading and escaping the controlling mechanisms. This is an interesting question by Carlos. Hi, doctor. If someone is exposed to COVID via ingestion, would that person have a more or a less severe disease as compared to if she had breathed the virus in? So, most of the time, so let me qualify. 4% of the people, 4% of the people can develop gastrointestinal COVID or COVID that affects their GIT. Now, this can happen from respiratory, that the virus got into the GIT, which would happen to all of us, and our GIT can handle it. But in some people, the virus would cause GIT infection. And I know that some of the folks here would, or the listeners afterward, would say that, hey, you are making this arrows on the stomach and the other GIT pieces, and there are acids, and that they would, enveloped viruses are especially prone to be destroyed by acids. Totally correct. The problem is that we are talking about coronaviruses. Coronaviruses are known. So study the book, you would see coronaviruses are known to cause gastroenteritis because coronaviruses have the spikes and proteins on them that protect them from the stomach acids. Now, having said this, Carlos, it doesn't really matter that it is ingested or not. There are 4% who can develop gastroenteritis. Normally, GIT based outcome is a little less severe in terms of the death, but people who get gastroenteritis by corona, they are also very much bothered because of the pain and the diarrhea and the fever. I've seen some patients that way. Lisu says, what happens to a person who is allergic to vaccines but needs a blood transfusion Do the blood banks separate vaccines and non-vaccinated blood donors? So I think many of the blood banks say that, hey, if you are vaccinated, then do not donate. And I think that the point is they don't want to accidentally hand over the antibodies, maybe for reaction purposes, but generally, I do not know. You'll have to ask the blood bank near you to say, hey, what is your policy? Do you use the imagine if somebody is not vaccinated, there are still asymptomatic folks who may have the antibodies. I do not know of any blood banks that actually remove the antibodies. Good question. Christ Left says, I love how you explain things. Thank you very much. And Doug says, this is cat, not me, Dr. Me. Thank you. Great cat. All right. So let's see if I can go to this side and see if there's more. So Garrett says, so we responded that. John Snyder says, I like the old office, by the way. Thank you very much. How about now? Is it becoming better? I am working more on it. And Lisu is here as well. He's saying, miss the bookshelf behind you. Here it is. And I'm still working on it. If you don't know, Paul Borg says, if you don't know how the baby generated AGAS directly, could this be a parallel process which oh, so I know what you're talking about. So we were talking about how babies develop IgAs when we know that their immune system cells usually do not produce other antibodies. So the question, a mystery for some of us, maybe there are other doctors, research workers who know, but some of us still are baffled that how does a baby produce IgA without going through all those class switching, or maybe they do. So I think that is a context. So Paul is saying, if we don't know how the baby generated IgAs directly, could this be a parallel process which continues in adults? I don't know how one could rule this out, not knowing how it works in infants, perhaps in all new aspects of immunity waiting to be absolutely possible that it may be that it continues in adults as well. You are correct. Okay, so John Doe says, could recovery from an infection limit risk from spike protein in a way that the COVID shot does not? Limit risk from spike protein in a way that COVID shot. No, they both should have a similar response to spike protein. They should both protect similarly. One more question here, then I'm going to come over for the live questions. Frederique Cotter says, it is a very difficult question. Should the world's population be advised to stop these COVID's jabs, as the factor of time is not one we can afford to take for granted? So, Frederique, I can only base my answer on the data that is provided. As we saw today, this news of whistleblower. Now, where are the errors in the data? I have always been saying that, hey, I'm going to present the data, and if there is a problem with the data, then my talk becomes wrong as well. So, similarly, based on the data that we have seen or have been presented with, then it is fine. But based on all of these anomalies, are there more? Are these just little indicators? If there are more, I would really want that there is transparency. The more transparency they can provide, the more trust would develop. So, to answer your question, it really depends upon the risk assessment. And with the given data, I don't know what is real. I can give you my example. I have Moderna, my wife has Johnson and Johnson, my son, older son has Pfizer, younger son has Moderna. We are all adults, and I've asked them that I can talk about their vaccines. Out of four of us, the only person who still has side effects is my wife and Johnson and Johnson. And ironically or tragically, Johnson and Johnson has lesser efficacy in the long run compared to others. So, so far, we haven't developed any long term effects, but we'll see. This vaccine, we don't know yet. So, if you asked me that, hey, will you take it? Yes. And that is, again, people who would now say somehow I am too sheepish to say no. No, I like vaccines. Vaccines are important to protect. Doug Rose says transparency, they have immunity. Yeah, ideally, they have gotten such contracts that they are immune. At least there should be transparency. So, Guy Gee says, is it true that there is a portion of population who cannot get COVID? I am not aware of that, other than somebody who already had COVID and maybe have a breakthrough reinfection with lesser symptoms or infection, sorry, vaccine. What's your opinion on lion's mane? No idea. No idea. I have never l- read that. So, Z Solo 2.0 should be 2.1 and 2.2. What about post vaccinated deaths? Those victims would still be alive had they not taken the shot. Post vaccinated deaths. Deaths because of vaccination, yes, they would have been alive if they didn't get the vaccine. The question, really, without being facetious or confrontational, there is risk from the virus as well, and there is a risk from the vaccine as well. And it is just, I think about it very often, that what a tragedy for us human beings, that on one end, if we say don't want to have a vaccine, then we risk the virus and risk death over there. If we say we want to have a vaccine, then we still put ourselves at risk. Now, majority of us survive it, but we still take a gamble. So it's a strange time. So there is Elias. Elias Moin, this says, what is the link between COVID and Darwinism? Evolution or just Darwinism in general? No idea. Um, COVID, please elaborate a little bit of your question. Is anyone getting anywhere with using a rhinovirus based vaccine yet? Rhinovirus based vaccine. I don't know. So Claire says, vaccinated blood not allowed for plasma donations. It makes sense because there are antibodies which could cause reaction. I wonder if there's any update on the Sinopharm or Sinovac vaccine. So I'll have to look that up. I had been looking more on the Novavax side. So Stays Jones says, will COVID cause cancer 100%? Question mark? No, because it changes cell repair. No, so see, that is the discussion we just had. Most of the cell that have the infection, they would be destroyed. So their DNA was repaired or not repaired, the cell would be destroyed. If some cell would escape the destruction, then if the cell is not killed, that is because its DNA is not misrepaired. Finally, if this study actually shows something that was happening this frequently, then everyone with SARS-CoV-2 or with vaccine would just developing cancers. And cancers are not something that you say, today a bunch of cells in deltoid or cells in throat became cancerous, and year and a half is spent and there is no sign of the cancer. So In that talk as well, I had said we have to map this to what we are observing as well clinically. And we're not seeing people getting COVID and then getting cancers. Connie White says, any difference between monoclonal antibodies immunity and natural immunity? So I would consider this that you're saying active and passive immunity. The difference between them, of course, there is a difference. And if you just look up passive versus active immunity, you would see the responses to passive and active immunity. So the passive immunity is where here is a person. I'll make a little neck. Do you know that if I make the neck of a person, then I do not know how to draw the person? So let's say this is a person. Yay, I did the person with the neck. So here is a person. This person, let's say, cannot make their own antibodies, or they would take time making their own antibodies, but meanwhile we really want to protect them, and we want to sweep the virus from their body because they may not survive otherwise. So for such a person, what we can do is we can give monoclonal antibodies from outside, which would go and mop up the existing antigen and kind of remove it. This is like sending a filter vacuum system from outside. But monoclonal antibodies themselves will not offer any immune system training. In fact, monoclonal antibody, the vials say on them that it is possible that your ability to respond to the infection in the future will reduce because here comes the virus and you send the monoclonal, which would come and wipe the virus off, and the immune system didn't have enough chance to be trained. So imagine giving a small dose of a vaccine versus a large dose. So similarly, giving a small dose of the virus versus a large dose because the monoclonals cleaned it. And so your response for the future is not as great. Active immunity, on the other hand, or as you're saying, natural immunity, which could be because of the infection or the vaccine. Active immunity means you have developed cells that have gotten this training for how to respond to this pathogen. That may be SARS-CoV-2 or other pathogens. How to respond to it, how to attack it. And now you have active immunity. Now, if the person becomes sick 2 months later, 3 months later, 6 months later, if those cells are present, they would wake up and they would respond. That is the difference between active and passive immunity. So Elias says, did you read the work of Claude Bernard and Antion Beckham, who had proven the idea of the germ theorists to be false? No, I have not. Okay, so let's do some questions from this side. So then we have now what? Now what says, can you compare COVID 19 to RSV in young children? Hospitalization data suggests RSV is still more dangerous. I actually believe that there are more other pathogens for children that may be more dangerous than SARS-CoV-2, at least in the data. There are many infections where children can become gravely ill and or die. And SARS-CoV-2 has generally been milder to youngsters. Joanne says immunity for general coronaviruses versus other illnesses, for example, flu. Flu mutates, yes. So understand boosters for this, yes. Chris Mattinson and said something like humans struggle with immunity to coronaviruses, which is why we catch the common cold all the time. Is this true, or does immunity to coronaviruses operate in the same way as other illnesses? If so, I'm going to assume COVID boosters don't make sense then. How wrong am I? Okay, so too many variables in this question, so let's answer them one by one. Immunity for general coronaviruses versus other illnesses, flu. So we know that flu mutates, and because of that, boosters make sense, and you agree with that. Chris Mattinson said something like humans struggle with immunity to coronaviruses. It is true that many common cold viruses, we just do not know how to handle them very well. And it's not only coronaviruses only make up 14% of the common cold infections on a yearly basis. There are others too, which are not coronaviruses and still cause infection and recause infection and recause infection. So it's not just the coronaviruses. Then, next part. Is this true, or does immunity to coronaviruses operate in the same way as other illnesses? So, common cold is a problem, viral infection, and we always get it every year. So, we know that respiratory viruses, some of them are just beyond us, our immune systems. Right? I remember when I was doing medicine, we used to have a poem that was written by someone, and it was to this effect: that doctors have solved this and solved this and solved this, and here I sit with my common cold and runny nose. So that is a problem, and it's not just the coronavirus, it's other viruses too. Now, if so, I'm going to assume COVID boosters don't make sense then. How wrong am I? So that's a good question. We know that on the respiratory system, in the respiratory areas, the coronaviruses can keep becoming a problem. But many of us have coronaviruses. I think 80% or more of us have human coronaviruses in us. But we don't get infected all the time by these coronaviruses. We have just learned to live with them. So for the SARS-CoV-2 as well, the first phase that is going to happen is that we're going to stop it from damaging us by vaccines, or the people who unfortunately became infected and have recovered. Unfortunate because that's a dangerous thing. They have become recovered fully, now they are fortunate. Um, in these cases, it's not the respiratory IgA production, it's really telling the immune system to produce IgGs and IgMs, and especially IgGs. And whenever that virus would come back, we would produce IgGs again. So it is really training beyond just a human. It is now possible in the future. SARS-CoV-2 will become a human coronavirus as well and just live in our throats without doing much harm. It would have changed so much, and our bodies would have developed enough immune system for it. Very good question, though. So Augie says, can chronic warfarin users get microclotting? Thanks. Ideally, they should not. But really, the point of the blood thinners is to tip the balance of clotting towards thinning or less clotting. That is how thinning occurs. But if you tip the balance again towards clotting by increasing the clotting factors and increasing the proteins that help with clotting and increasing the cells, platelets, and others that would help with the clotting, then all of a sudden you have clotting propensity. So it really depends what is the person's clotting propensity, and if the warfarin is helping in enough dose to reduce that propensity. So that has to be checked by labs. It's not a general answer I can give, but good question. Okay, so how about we stop here for today? There is a time zone, a time change as well, a Pacific time, sorry, daylight time too. So I'm glad that we are actually able to go through some questions fast. Do me a favor. So, one more question. There are many questions, but this is intriguing me. So, let me just quickly. Um, think about this one. Gary S says, is there an off switch for the spike protein production once vaccinated? Yeah, so I have done a video talk where I talked about how long the vaccine will produce spike proteins. Then I talked about a Pfizer study as well, which some doctors continue to use it incorrectly to say that our bodies produce spike proteins. Anyways, I've done these two talks. In those talks, I have discussed from a mechanism point of view how long spike protein and how much spike protein can be made from a vaccine. And the other is a study where they observed that spike protein, a higher intensity in the deltoid was made for 2 days. Then the spike protein stayed in the body, or I shouldn't say spike protein, LNPs, and those stayed in the body for up to 9 days. So there is a 2 days to 9 days in various concentration in various body tissues. I would repeat it. I know that folks then become upset with me, and then they do all kind of things, but it is an incorrect concept that is being peddled by some of the doctors to say spike protein is produced by body's tissues. Okay, cool. So thank you very much. Please like, subscribe, and share. The smallest thing you can do back for me is to hit the like button. And if you want to do a little more, you can support this work as well. There are links in the description. You can buy me a coffee, or you can be a patron, or you can use PayPal. Thank you very much, and I would see you tomorrow. Bye bye.